values and preferences. So critics of evidence-based medicine movement are saying, well, this is like cookbook medicine. No, it's not. The evidence and the statistics and the epidemiology is just a part of this process. A little bit of history because it's all fun. So people started to talk about papers back in time. And the famous William Osler, who is such a central figure in the Western medicine, he instituted the practice of reading medical papers at McGill University. And Paget, he too, and they have this charming description of finding this room over a baker's shop near the hospital gate, just to get together with colleagues and talk about published papers. But the modern clinical epidemiology was actually founded at McMaster's University when they first had in 1967 a clinical epidemiology course, and they developed the method or the strategy of applying critical appraisal at bedside. And the term EBM was basically coined in 1991. So why, even from the very beginning, the evidence-based medicine was born from the desire of opposing practicing medicine based on expert opinion, based on authority, based on people who claim they have mastered the art of medicine. And in reaction to this, they said, well, we need to see what is the actual proof, what is the evidence. And ironically, we are still there these days when we have to kind of defend the science-based aspect of medical practice against a lot of hype in the media and in all kinds of circles where people, they might be experts in some fields, but we need to question the basis, the scientific basis. So that's the point where I would like to start. How do we evaluate this scientific basis of medical practice? So there's a nice description of different stages. We always start with a patient dilemma or a question that is a clinical question that is based in a need that is driven by a patient problem. So we ask a question, then we acquire that information, then we appraise that information, we judge it if it is of quality or not, and then we go back to the patient and we apply it, and then we go back to more patients and we apply it and see how it works, and maybe we can generate even more questions. So each of these elements can be a field in itself, how we even find, how we acquire the best evidence. And people who are, librarians and people who are skillful in the acquisition, they can help us. But what I'm going to focus on strictly today is appraisal, how we judge a paper. And we have to take it slow and step by step to understand how we build that judgment of a paper. So when you have a clinical question, where do you go for an answer? You can go to look into clinical guidelines. If that information is not available, you might go into a systematic review or a meta-analysis. If that is not answering your question, you have no choice other than to go to primary studies. And this is what we are going to do today. So we'll start with a patient case. We have Maria, a 59-year-old lady. These are her patient characteristics. Not too bad, but she has a family history of maternal diabetes, and her concern is right now being postmenopausal and starting to think more about her health. she is considering options, what would be the best diet for her. So this is why she is coming to you as experts in lifestyle medicine. So what do? What would be your next step? Assuming that you don't know already the answer. You might know, but let's assume you don't know the answer. And what would you do? You go and acquire some literature and see what is out there to support one sort of diet or another. And let's say you are finding this paper that you think it's interesting. It was published in JAMA, and it talks about Mediterranean diet and onset of diabetes, specifically in a study that enrolled women. And this is a famous study in the United States. It's called Women's Health Study. So now you'll have to digest this paper. And this is what we are going to do next. I always recommend when you see a paper, start with the big picture first. And the most efficient way to get an idea, to get the coordinates of where to place this paper is to use the PICO model. Find, as soon as you open the paper, find these elements: patient, intervention or exposure, comparison, and outcomes. This will lay the ground for understanding what's going on without getting lost in small details, and also will lay the ground to start critiquing these elements one by one. So you can see, once you get used with this PICO model, you are going to be able to see it more and more. The more you think about it, the easier will become in seeing. So even in the title of this paper, you can see the PICO. Can you tell me what are those elements? The patient population, the intervention exposure, the comparison, and the outcome, just based on this title. And this is why I didn't even give you the paper yet, just for you to see that, well, you know, we can put it in those terms, even looking at the title and nothing else. Anybody would like to jump in? Population, intervention, exposure, comparison, and outcome.
Can I say?
The patient,
yes, please.
Women's. It's about women.
Yes. So the P, the population, is women. What is the, very good, what is the intervention or the exposure? The exposure and the comparison.
It is the Mediterranean diet. Exposure.
Mediterranean diet, exactly. We don't know, it's not specific enough to tell us compared to what, but we'll find out. And the outcome of interest?
The onset of diabetes.
Absolutely. The new onset diabetes. So that's our PICO. Excellent. So if the title is not suggestive enough in a paper, just by glancing at the abstract, it should become pretty obvious. And I personally, once, you know, I got used to these methods, I don't even read the entire paper from the very beginning. I'm scanning. First, I'm scanning the abstract, and I go fishing for my PICO. Where is the PICO? Really trying to get an idea from the abstract. And then I go targeted for other elements just to figure out if it is even worth investing time to read that paper or not. So we can get this idea. Now, any paper, and I'm sure you already know, we have this structure, introduction, methods, results, and discussion. And in each of these sections, there are specific things that we can learn about. And I like to think about a paper in terms of looking at the methods, again, looking at the PICO in more details, looking at the design. And I am a very visual person. And I recommend everybody, especially at the beginning, to diagram the study. And even if you do it in your own mind, or you are just scribbling something on the back paper, just to understand the general structure of a paper. And many published papers these days, they are coming with what is called a visual abstract, but not all. So I highly recommend, and even if they have a visual abstract, it doesn't mean that is super intuitive. So do your own diagram really quick, or figure it out. What is the target population? Meaning here in our case was like postmenopausal women, but that is all the women in the universe, so to speak. But the problem is that they enrolled in the study only a fraction. You can't study everybody on Earth. So this is the enrolled population, and this is the patient population that the study is addressing, and then figure it out. What is exposure, exposed, non-exposed? Some groups, there can be 2 groups many times, but it can be more than 2 groups. There might be a follow-up in time, or not, but that is what is the outcome of interest and what are the results, and then a conclusion. So basically you could tell everything about a paper in one single diagram, right? Just the bare bones for the results. And I am aware that what I'm saying may not make perfect sense right now, but we will go a little bit in a spiral. So these are the things that we will look into. What are the results of the study? And my students, it's like every year they do the same thing. They think that the results of the study is some sort of fancy statistic. And they are coming up with p-values, God knows. No, the results of the study is the actual numbers. How many people died in group 1? How many people died in group 2? I want that percent. Those are the results of the study. This is the way we understand, and later we can put the statistics on it. So this is why I mentioned, it's not about statistics. Statistics is the cherry on the cake. The understanding is much more simple and much more intuitive. So give me the actual number that happened in each group. Second, give me the comparative numbers, and we can call it effect size. And that can be quantified as relative risk or odds ratio and different kind of fancy names, which we will go over. So the comparative numbers. Third, okay, these are the comparative numbers. Is this a statistically significant difference or not? Could these results just come out by chance only, or no? And that's statistical significance. And absolutely critical, follow with the discussion on the clinical significance, because not everything that is statistically significant has any clinical utility or meaning. And as statisticians don't know, but we know because we are practitioners. So we have to put those results into context, regardless if the paper says anything about it. And most of the time they don't say anything because they may not like the conclusion. They don't go into that direction. And then we discuss the paper. So what does it mean to discuss? We have to address this, what I call the threats to the validity of the paper. And these are the 3 elements: discussing the role of chance, confounding, bias. And this will have to be over and over again every time that you talk about a paper. Discuss these 3 elements. And it can take a really long time to go to the essence of all these 3, but all 3 need to be discussed. Otherwise, no point. So what can go wrong? And I don't expect you to follow the entire diagram here. This is just saying that we are always looking to discover, what is the truth? What is the effect of an intervention in a particular medical condition? Then we have our sample, and then we have the results in our sample. A lot of things can go wrong, meaning the data is distorted and the results are not, the results are biased. So we have to, again, embed in our discussion the role of chance, the role of confounding, the role of bias, and to clean it up, the conclusions based on these three important pillars. So then we proceed to the conclusion. What about the paper? And there are all kinds of mnemonic here, but basically we are looking at the criteria for quality being met. And this is not a black and white conclusion. It is always, all papers have some weaknesses, but with time we learn how much, we learn the shades of gray. It's a lot of bias. Can we trust it at all, or we trust it a little bit? This is actually all we can do with a paper. Critiquing a paper is not only what the paper is saying, the strengths of limitations is our own judgment. Because the papers just say whatever they want to say, but there is a lot that is not being said in the paper. And this is where critical thinking comes into place, going beyond what is written in the paper. Of course, looking at conflicts, and there are a lot of conflicts, and it's not only commercial, there are a lot of non-commercial conflicts. Even in academia. So this comes with practice and getting to learn who is claiming what and what is behind their reasoning or motivations. And then, of course, the conclusion, if we accept the author's conclusion or not. Is it a practice-changing paper based on the information available? Are we going to change something? Will the clinical guidelines change? That type of discussion is important. So I recommend first do a speed reading of the paper, figure out the design, and we'll talk about that. But basically, at the very beginning, you have to make a determination if it is an observational study or it is an experimental study. Most of the time, a randomized clinical trial. That's a crucial thing to put very early into your mind. So you have that. Then you get idea about the PICO population. Who are the people? High risk, low risk, depends. What's the exposure? What's the comparison? Placebo or another intervention? What kind of outcomes is the study addressing? And then you look into the absolute effect. And that is what I mean, the numbers. X% of people died in group 1, X% of people died in group 2. And then you can do, and we'll go over those measures, what we can do with these absolute risk measures. There are also relative risk measures. Both are important, but I'm emphasizing the role of absolute measures because that speaks to the clinical significance of a paper. Next, you think about assumptions, biases, confounders. What are the assumptions made in this study? And they are not explicit. They are not writing those in the paper. We have to figure them out. And then, of course, what are the implications, the importance of the results, clinically significant, if it applies to your patient, and completing that circle that we started with. So this is what I recommend as the first quick glance at a paper. So right now, I would like to